Okay. So hi, good evening everyone. So hi guys, good evening. I hope that the audio video both are clear at your end. So I think we are ready to start. Hi, good evening. So I think we are ready to start the session. All going good. So exam is just a couple of days from now. I think there is some. Hello, 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 hello. I think audio is creating some issues. So I've done some changes in the audio settings and I think now it should be a little bit okay. Now, yeah. So I think now the audio is fine and you all can hear me very, very clearly. So guys, today's session uh, is of orthopedics. I am Dr. Sushil, your orthopedic faculty at DBMCI, and today's plan is to discuss all the questions that you have sent me. That sir, these are the things which I want. Okay, so just a quick recap of the yeah. So the plan is now to discuss and revise all the things that we can, right, for your exams in this 1 hour session that we have today. So, I got request about many a things, revise the whole content, revise the whole topic, which practically you also know is not very much possible. Okay. So, what I'm going to do, I'll take all your, okay. So, what I'm going to do is I'm going to take up all your requests one by one, right? And I'll just try to show you certain videos. I'll try to show you certain images which are important. Okay. So the one request which I got is about the test, the various tests and various angles that we see in orthopedics, because the INI is just couple of days from now, and matching side A with side B is one thing which is being asked regularly in your INI exam. In the earlier exam, they asked about matching the fractures eponyms, Potts fracture, Cotton's fracture, Mazzoni fracture, Pylon fracture, with the counter, names basically. And what are the other areas from where the same types of questions can be asked? They are, as I said, we are starting from the, the clinical test, the names of the clinical test, what all are important. Yeah. So clinical tests in orthopedics. What are the different tests which can be asked to you, which are frequently asked to us, and which you are expected to remember? Okay. So starting the important ones, starting from the upper limb. When you talk about the wrist area, there is one important test that is about the median nerve, and that is known as the Durkan's test. So what exactly is that Durkan's test? Durkan's test is compressing on the directly on the course of the nerve, the median nerve here at the flexor retinaculum. So that is for your carpal tunnel syndrome. So Durkan's test is for our carpal tunnel syndrome, isn't it? That's for carpal tunnel syndrome. Number two, for the same carpal tunnel syndrome, we have other tests as well, which are, one is Phalen's test. One is Phalen's test. So what is Phalen's test? You ask the patient to flex both the wrists like this, and you try to produce a compression on the course of the nerve. So remember that the most sensitive test for carpal tunnel, it is Durkan's only. Durkan's is the most sensitive test. It is the most sensitive test for carpal tunnel syndrome. Okay, that's the Durkan's test. That was the old question of your aims only, right? So Phalen's, and then other for carpal tunnel syndrome, there are non-specific like reverse Phalen's. You can do tourniquet test, the tunnel sign. These are only for the carpal tunnel syndrome. Okay. Second is second is when you go from this wrist area, when you go to the side of the hand, for this decurvains, when you talk about the decurvains tenosynovitis, decurvains tenosynovitis, then what are the two tendons which are affected? The two tendons affected in decurvains tenosynovitis, they are your abductor pollicis longus and the extensor pollicis brevis, isn't it? APL and the EPB. And the clinically done test for these disorder is what we call as the Finkelstein test. Remember that? It is the Finkelstein test. So how to do that Finkelstein test? Ask the patient to keep the thumb in the fist and go for ulnar deviation like that. So if this area is tender, he won't be able to do that. Okay, so carpal tunnel and lateral side of the thumb. The named test for the soft tissue conditions. Okay, mind that I'm not taking the name of the test which are due to the nerves or all, but here's the soft tissue conditions which are commonly asked. So decurvains going up to the elbow area, there in the for the lateral epicondylitis. What is the name of the test that we do for lateral epicondylitis or the lateral epicondyle inflammation? What is that? The tennis elbow. What is the clinical test known as? For the tennis elbow, the clinical test known as is known as the Cozen test. What exactly is the Cozen test? Ask the patient to flex the wrist, flex the elbow, and just against some resistance, try to extend the wrist like this. So if the patient is not able to, if he is having some pain over here, inflammation over here, it will be tender. The movement will be tender. That is Cozen test. Okay. Number 4, when you talk about the the thoracic area, the thoracic outlet syndrome, then we have for the thoracic outlet syndrome. For the thoracic outlet syndrome, what is the test? What are two tests which can be done? One is what you call as the Roos test. One is what you call as the Adson's test. So what is that Roos test or what is the Adson test? That was the image-based question, if you can recall from the previous year. How the Roos test is done? Ask the patient to just abduct both the shoulders like this, extend a little bit. Ask the patient to just keep on closing and opening the fingers like that. So on whichever side you're suspecting the vascular compromise, the pulses here, the radial pulses here will become feeble, because thoracic outlet syndrome is what? The compression of the subclavian vessels or the lower trunk of the brachial plexus under the clavicle or the cervical rib, and on the back side it is the scalene muscles, right? So Roos and the Adson test over here. When you talk about clinical test, clinical examination of the back in a child, when you talk about the spinal area, we have certain tests. For example, when you talk about the scoliotic child, when you talk about the scoliosis adult, you ask the patient to stand straight and bend forward, just to compare that whether the scoliosis, it is a pathological one or it is all because of the long stature of the patient. That is a postural one, right? So what is that known as? For scoliosis, when you ask the patient to stand straight and flex forward, bend forward like that, that's what you call as the Adams test. Okay, that is what you call as the, yeah, that's what you call as the Adams. Adams is just a fancy name. You all know that it is being done just to check for the scoliosis whether it is a real one or a postural one. Okay, then associated with the spine, you talk about the test of the sacroiliac joints. The important one which you will read in your all the time in your literatures as well, in your classrooms as well. For sacroiliac joint, what is the test done? For sacroiliac joint, the test being done, it is known as the Ganselin's test or the pump handle test. And how to do that? It is being done when you try to open up the sacroiliac joint, right? It is being done as you try to do the or open the sacroiliac joint. Let me show you the pictures, the video side by side. So I've taken this video a long back from the net only itself. In this patient we are trying to do the Ganselin test. In the young lady, we are trying to do Ganselin test. So what happens here? We are trying to test for the sacroiliac joint, and this is being done for ankylosing spondylitis. So we know that in ankylosing, the first joint will be involved is sacroiliac joint, and that is why we try to do that. So patient lies on the edge of the couch. The side being tested is made to go into extension, and the patient is asked to hold the other side. So one hip flexed, one hip going into extension. So that tries to open up your sacroiliac joint. And if you do the opposite movement, that means the left knee from here goes to the right shoulder, or the right knee goes to the left shoulder. That's what you call as the pump handle test. Okay, that's what you call the pump handle test. Now, these are the two tests which are done for sacroiliac joint, and as you know that the sacroiliac joints are the first one to get involved in ankylosing spondylitis. That's why we are getting it done. But the point is, for ankylosing spondylitis, what is the most specific test that you do? So for the mobility of the lumbar spine, when you want to check for the mobility of the lumbar spine, the motion around the lumbar spine, what test you do? What is the test known as? That is what you call as the modified Schauber's test. That is known as the modified Schauber's test. So modified Schauber's test. That's the modified Schauber's test. Okay. So Adams test, Ganselin test, pump handle test, Roos, Atson. These are the tests. Okay, for the spine. When you go to the lower limb, the test that can be a part of your exam, they can be the most important one. At hip, the spine, the lower spine, we say, is something known as one of the most important tests, and that is the Thomas test. And I believe all of you know why we are doing the Thomas test, for what it is being done. So Thomas test is done for the fixed flexion deformity of the hip. I hope you are aware of that. So Thomas test, why it is done? It is done for the fixed flexion deformity of the hip. It is done for the fixed flexion deformity of the hip. Right? This was a very, very recently asked question. They asked from you the steps of this test, isn't it? They asked for the step of these tests. So what are the steps that you can do for these? Okay, what are the tests? What are the steps of this test, the Thomas test? Just a moment. Yeah. So what are the steps? I would just like to show you Thomas test as well. So Thomas, how to do that? Thomas is done, as I said, for the fixed flexion deformity of the hip. So fixed flexion deformity, what does that mean? That from a fixed attitude, the patient can further flex the hip, but he cannot extend the hip. For example, the test that the patient that you're seeing right now on the screen, he had tuberculosis of the hip joint. He was a very old patient of mine. He had tuberculosis of the hip joint. He was treated conservatively. He was a rickshaw puller by profession, right? So obviously for his living, he had to do work all the time. So he was not taking proper rest. So at last, after completing the treatment, this is what the posture is. So now the rickshaw puller gives you the complaint that, sir, whenever I'm riding my rickshaw, right side is all right, but the left side, I always get hit from my pedal of the rickshaw because there is some deformity. I'm not able to straighten it properly. So if you see the left hip, see the left hip, he is not able to keep the left hip on the couch. That means the left hip is off the couch, off the ground, you can say, off the couch, you can say. So he's making some angle with the bed. How much? Seems like some 15-20 degrees of the angle, right? So he says, sir, please correct my deformity. This is just some very little deformity and we can easily correct it, isn't it? So what actually happens is, due to this fixed flexion, that means this much of flexion is fixed. He can flex from here further, but he cannot extend it. So what is the problem? This is not the real flexion. Actually, he is hiding his real flexion. How? By increasing his, see the pointer. I believe that all of you can see the pointer. By hiding his exaggerated, by increasing his lumbar lordosis. So he's hiding his real deformity by increasing his lumbar lordosis. So in the Thomas step, what we do is, first step is always to obliterate the exaggerated lordosis. How to obliterate it? First, the examiner will confirm the exaggerated lordosis by introducing his hand on the patient's lower back. So my hand easily goes in. So what I'm going to do now, I'll be flexing the hip. Normal side. So what happens because of that? You can see the lower back. All of you can appreciate that. Once we flex the normal hip, now the lower back will be straightened, somewhat straightened. That means exaggerated lordosis will be obliterated. Exaggerated lordosis will be obliterated. Now see, exaggerated lordosis obliterated. Now see, this is the angle. So this is the real angle of fixed flexion. So he's not having a deformity of 20 degrees. He's having a deformity of almost more than 20 or 30 or 40 degrees, almost like that. And if now I try to introduce my hand, it will not go in. That's what you call a Thomas test. So please remember, in Thomas test, the most important step would be to obliterate the exaggerated lumbar lordosis. Right? So exaggerate the, just block the exaggerated lordosis, and then you can see the real deformity. That's the Thomas test. Then in the knee area, what are the tests which can be done? In the knee area, there can be various tests done, right? One, if we talk about, let's suppose, the cruciates. If we talk about the cruciates, then we know that we have got the drawers test, anterior and the posterior drawer, anterior and posterior drawer, and or you can say the Lashman test. How to do that? I'll just show you the videos for that. So anterior and posterior drawer and the Lashman test. Okay. Similarly, when you talk about the menisci, we have two tests. One is what you call as the Macma test, which you often fail to understand. Macma test, and the other test is what you call as the Appley's grinding test. Other test is what you call as the Appley's grinding test. Now, how to do these tests? For the collatals, you know that you have to move the leg in valgus or varus. So they are known as valgus or varus stress tests. They are known as valgus or varus stress test. Okay. So I'm just going to show you how these tests are done. Just have a look. This is my knee video which I've recorded just for the understanding of. The patient is lying supine. Okay, the patient is lying supine. So what we need to do is, we flex the patient's knee to almost 90 degree. Okay, we flex the knee. First we are doing the draw test. So first we flex the knee to 90 degree, and then the examiner sits on the foot of the patient. Why the examiner is sitting on the foot of the patient? Because to stabilize, so that the foot is stabilized, the tibia is stabilized. Now what we do, hold the upper leg, hold the tibia from the proximal end and try to translate it anteriorly. If you are able to do it, that shows that the ACL, anterior cruciate ligament, is damaged. If you are able to push it back, that means that the posterior cruciate ligament is damaged. That is for anterior and the posterior cruciate ligament. But this is done, please remember, this is done with the knee in 90 degrees of flexion. If you want to do the Lashman test, how to do it? Lashman is done with the knee in only 15 to 20 degrees of flexion. How? Just flex the knee to 15 to 20 degrees. Just flex, just a moment, I'll open up another video. Yeah, so just 15 to 20 degrees of the flexion of the knee is required. This we have been explaining the same. Yeah, now see what we do. Flexion of the knee at 15 to 20 degrees, and then what we do is, examiner holds on the lower femur by one hand and the upper leg by another hand, and we try to translate, see this. So holding femur by one hand, okay, stabilizing femur by one hand, by other hand holding the upper tibia, and now I try to pull it anteriorly. So Lashman is the test of choice for any acute injury. Please remember that, because in acute injuries there will be some sort of effusion, there is pain, it's acute trauma, and if you try to flex it more, what will happen is you can damage the ligaments more. It will cause more trouble to the patient. Okay, so Lashman will be done in only 20 degrees of the flexion of the knee. Then we talk about the Macma test. Macma is something which I have often seen, students getting confused. Yes, it is little bit tough to understand, because the Lashman, there are three movements which are being done at a time. Okay, how it is being done? Just try to understand that. Okay, I think my video is getting stuck, but I think the audio is clear to all. You all can understand. So I have just stopped my video for a while. Okay, I think there is some trouble. So I've been trying to show you the movement. I think my video is stuck. Is the video going fine, guys? Can somebody please confirm? Is the video fine? If some of you can just reply that, is the video fine, so that you can easily see the test. So now what I'm going to do is, I'm just going to show you how the Macma is done. So as I said, Macma is a blend. It is a mixture of three movements at a time. Okay. Now see what we do. The step one is going for hyperflexion of the knee, extreme of the flexion of the knee. Why is that required? because you know that the menisci, whenever you hyperflex the knee, if you talk about the structure of the menisci, this is how any menisci is there between the femur and tibia. So when we hyperflex the knee, what happens is only this part of the meniscus is getting crushed. As we try to, from the flex state, we try to extend our knee, it goes straighten and it goes straight and it goes straight and it goes straight like this. So it keeps on covering more of the meniscus, more of the meniscus, more of the meniscus, more of the meniscus, like that. Okay, so when we are hyperflexing the knee, we are actually testing for this part of the menisci. Now see the video how it is being done. Patient's knee is hyperflexed now. And now after that, what happens is the second step is, yeah, okay, it is going okay. So now what happens is we are flexing the knee so that only the last part, terminal part of the meniscus is getting crushed between femur and tibia. Second step is extreme external rotation of the foot. We are checking for one meniscus one by one, medial and lateral, right? So what we try to do is, first we try to check for the lateral menisci. We try to crush the lateral menisci. How? First, hyperflexion of the knee. Second, rotation of the foot laterally completely. Third step would be putting my hand on the knee area and then extending the knee. And while extending the knee, I'll be, keeping the leg or putting a lateral stress, valgus stress on the leg. So actually not three, there are four components. First is hyperflexion. Second is external rotation of the foot. Third is keeping my hand here, extending the knee, and while extending the knee, putting valgus stress on the knee. So if the patient tells me that, sir, the pain was very much when the knee was hyperflexed, that tells me that the posterior part of the menisci is damaged. Once the pain is there in the middle part of the flexion, then it is the middle part of meniscus which is gone. And if it is on the complete extension, I know that it is most likely the anterior part of the menisci which is gone. That is your Macma raise. Okay, so Macma raise involves multiple movements at a time: hyperflexion, rotation of foot, extension of knee, as well as putting the valgus or the varus test, depending on what menisci you are checking. Okay, that is one. Other one is the Appley's grinding test. What exactly is the Appley's grinding test? What is Appley's grinding test? Appley's grinding test is asking the patient to lie prone. By your hand, you try to push the foot of the patient down, and then you try to grind it medially and laterally. So this is something, not very comfortable test. You can do more damage. Instead of providing relief or testing it, you may damage the structures more. So that won't be a good idea to go ahead with the test. That's why we don't encourage the Appley's grinding test very frequently. We don't encourage it very, very frequently. Okay, so this is your Appley's grinding test. So Lashman, drawer, McMurray's Appley's grinding knee. Then, the test in the lower limb, one important test in the lower limb, it can be the test for the tendo Achilles, and that is known as Thompson test. That is known as the Thompson test. So what exactly is the Thompson test? Thompson test is basically done for checking the integrity of the tendo Achilles. It is done to assess the integrity of tendo Achilles. It is done for checking the integrity of the tendo Achilles. Okay, how do we do that? Tendo Achilles integrity. The patient lies prone, similar to the Appley's grinding, and then flexes the knee, like in the Appley's grinding, same. But what we do is we squeeze the calf of the patient. Once you squeeze the calf of the patient, you are basically squeezing the gastrocsoleus complex. So if the tendo Achilles, which is attached to your calcaneum, if it is intact, what happens? The calcaneum goes like this. It goes into plantar flexion. So you squeeze the calf and the ankle goes down, plantar flexion. Okay. If there is a breach in the tendo Achilles, it will not go down. So these are the different tests for which are important ones, which can be asked in your exam, as a part of image based question, as a part of theoretical, MCQ. So these are the ones which can be asked. These are the ones which have a higher tendency to be asked by any of the examiner in any of the exam. So these are the different tests. I have no idea, no clue why the video is getting stuck. Okay. So the net speed is fine. I'm unable to understand why the video is getting stuck again and again. I don't find a reason for the same. The net speed is very good as of now. Okay, so this is one which I got as a request to discuss about the instrument file, about the instrument and splints. So guys, let me remind you that the instrument and splint file, the instrument and implants, the splints and traction, the splints and traction. These are two PDF which I have already shared on my Telegram DBMCI Premier group. So you can download from any of the groups you want. Go there and download them. So they are available. Just go through them. Implants, instrument, and in fact, I have recorded one video also on instrument and implant. So you can see that video also. In the eGurukul app, it's in the section. The clinical examination, the instrument implant are always already there as a part of main app. Clinical examination is there in the the examination part, the clinical part of the video, as well as this is available on YouTube as well. So you can just search the Telegram group of DBMCI or my Telegram group, and you can download these files from there. Go through these files before you go to your exam. One instrument, one implant is at least expected in the examination, which we are seeing every year. Okay. Okay. Okay, fine. Now I think the video, audio both are going fine. Now there should be no trouble at all. Okay, so these instrument implant file I have already shared. Now talking about certain angles, what are the different angles that we talk about in orthopedics? Okay, so eponyms can be there, angles can be there in the INI exam. They can be exam questions for your NEET exam as well. So angle used for orthopedics, number one, it is around the elbow. What is the angle that we talk about the elbow? It is the Bowman's angle. Remember that? Why we talk about the Bowman's angle? So Bowman's angle is seen for assessment of a proper reduction of the fracture supracondylar of humerus. Fracture supracondylar region of humerus. How much is the normal angle? It is 64 to 81 degrees. And we say that more than 81 degrees, it is suggestive of what deformity? The varus deformity. It is suggestive of the varus deformity. So one is elbow. One is elbow. Second angle that you should remember is the angle around the spine, the vertebra basically. What condition? The scoliosis. What angle do we talk about there? The Cobb's angle. So please do remember it had been already asked as an image based question in the previous years 2020-21. It has already been asked. So you should be aware of that. Number three. Number three is around the angles when you talk about the special angles. Then angle in the upper limb bones, only one. In the spine, only one. In the lower limb, when you talk about angles, you should know the angle around the calcaneum bone. What are the two named angles? I'm just talking about the named angles. One is Bowler's angle. Remember that? How much was normal Bowler's? It was 20 degrees to 40 degrees. And other one, other one is what you call as the crucial angle of Gisane. Other one is the crucial angle of Gisane. So how much was that Gisane's angle? Gisane is 100 to 120 degrees. 100 to 120 degrees. Okay, and then fourth is around, the fourth one is around the foot. The fourth one is around the foot area. Fourth one is at foot. What are the angles that can be seen in the foot? Basically they are related to actually the CTV components, right? So in the CTV, what are the named angles? Named angles, I believe that you have learned the angles of the CTV. What angle do we see for cavus? What angle do we see for adductors? What angle do we see for varus or equinus? So I believe that you already know about it. What are the angles seen? So when you talk about the cavus deformity, the cavus is something which is making or made due to high arch. So cavus is seen between the talus and the first metatarsal. It is seen between the talus and the first metatarsal. How much is the normal angle? Till 4 degree we say it is alright. Okay. And if it is going more than 4 degrees, we label it as a case of cavus. And if it is a flat foot, it will go up to 0 degrees. That's what you call a flat foot. That's what you call a flat foot. So cavus is basically a Meyer angle. That is a fancy name for this. The talus first metatarsal angle, that's known as Meyer angle. So remember the name of the angle is Meyer angle. Named angle is in the varus also, between the talus, when the talus and calcaneum, they show you angle. What is that known as? That is known as Kite's angle. So these are two named angles in CTV. For equinus, there is no name, but these are two named angles in CTV. One is Mare and one is Kite. So Mare angle and the Kite's angle. So crucial angle of descent, the Bowler's angle, scoliosis, the Cobb's angle, the Bowman's angle. These are named angles that you should be aware of. That you should be aware of, right? The named angles. So eponyms, I do believe you all have seen or all have read the eponyms of the fractures, like Cooley's, like Smith, like Barton, like Schoffer, Montegia, Galizzi, the the eponyms around the ankle area, the different names of the fractures around the spinal section, vertebra. So I do believe eponyms is something that you have read already. So eponym has been a question in previous years in the IMSS exam, can be asked in the upcoming exam as well, right? Now, after this, tell me what all you wish to discuss with me. So three things, three most important thing I have already discussed with you. You asked me about the CTV deformities and angles. I have told you that. Okay, and about the instruments, I have shared the file with you, the YouTube link of the file that I have shared already with you. After that, what was the request? Okay, the request is about sharing the file of the tumors that are on the one page. Okay, so guys, by this time, I do believe that you have already read everything. There is no point in going back and just changing your mode of studying. But this is, if you ever want this file that you are asking me to post, this is the file that you are asking me to post, and this is already there on all the Telegram groups. I've already shared it multiple number of times. You can easily download it. This is one image which is trying to show you all the tumors in just one page. Epiphyseal lesions are 2, giant cell tumor and chondroblastoma. Metaphyseal are usually 6, like non-ossifying fibroma, osteochondroma, aneurysmal bone cyst, unicameral bone cyst, or osteoblastoma or the osteosarcoma. Diphyseal lesions, 2 benign and 2 malignant. So benign lesions basically fibrous dysplasia and osteoblastoma, and the malignant lesions are Ewing sarcoma and adamantinoma. And if you have a question about the lesions in the vertebra, can be a possibility that it can be hemangioma. So this image is already there on all the social media platforms. You can very easily download it. You have all revised it, go through it very quickly, and it is involving, or it is mentioning all the points about all the lesions. Okay, so this is one. So this is about the tumors. Okay, right, right. So what happened here? Okay, so this is what you asked me. Yeah, the image. This is the one tumor image that we were talking about. Okay, that is a one tumor image what we are talking about. And yes, the deformity part, you should remember the deformity part. I'll just put all the deformities which we see in different conditions, common conditions. What are the different deformities? What are the different deformities seen in what are the different deformities seen in different conditions? So please remember, when you talk about the elbow area, when you say elbow, it is cubitus and cubitus varus, which is also known as gun stock deformity. It is seen because of malunion of fracture supracondylar humerus. Malunion of fracture supracondylar humerus. And the valgus, cubitus valgus deformity, it is seen in non-union. It is seen as non-union of fracture lateral epicondyle of humerus. Okay, then in the second, in the coxa vara, when you talk about the hip area, the coxa vara, it means the decrease in the neck shaft angle. So there is a decrease in neck shaft angle. So when you talk about a decrease in the neck shaft angle, what all conditions can produce this? Obviously the most important one remains your fracture neck femur. That's a traumatic one, but without trauma it can be seen in rickets. Then it can be seen in a tumor called fibrous dysplasia. And what do we call it there in fibrous dysplasia? It is known as the Shepherd Crook deformity. it is known as the Shepherd Crook deformity. Okay, that's fibrous dysplasia rickets non-ossified fibroma. Coxa valgus is not having any pathological specific condition that you should remember. It's only seen in Gardens type 1. So I can write it down. When you have a patient with fracture neck femur, the fracture neck of femur, which grade? It is a Gardens, as per the Gardens classification, it is Gardens type 1. It will be Gardens type 1. When we talk about the knee area, so please remember that the genu deformities, they are not very special ones. They can be seen, both of them, they can be seen in rickets. They both can be seen in rickets or osteoarthritis. And valgus as well, same, rickets and osteoarthritis. So varum and valgus can be seen in both the conditions. Okay, so this is one deformity part. Remember that when you talk about the special deformity, for example, when they ask you the hallux valgus, remember that the hallux valgus where the grade 2 is deviating laterally, it is usually seen as a part of rheumatoid arthritis. It is usually seen as a part of rheumatoid arthritis. When they talk about the deformities of the hand or the involvement of the joints, then swan neck and bottonia, you know that the swan neck and bottonia, they are a part of again rheumatoid. On the other hand, when somebody comes to with nodular swelling on the DIP or the PIP, they are a part of osteoarthritis. So Herbert's nodes or Butcher's nodes. These are nodular swellings of the IP joints of the hand, and they are a part of osteoarthritis, right? So remember the deformities, how they are seen, why they are seen in a particular disorder. That's very, very important. So do remember them. So rickets, OA, RA, osteoarthritis, rheumatoid, like that, fracture neck femur, and these all make our MCQs in all our exam, right? So these are 3 or 4 potential areas. Lateral epicondyle, great. You are right. Sapna is right on all the 3 topics. So deformities. Now let me know. I have covered all the 3 important areas from where multiple questions can be framed. Now let me know what else you would like me to cover up, so that I can tell you the short, in short about how to remember all those things. Anything, guys? Anything else that you would like to put? You put me just spine braces. For spine braces, Nalini, this file, I'll open up the file for you so that you can see and you can download that file from the Telegram group. So this is the file actually that I have. This is the file on which I have shared everything. This is a PDF. So splints and tractions and yeah. If you used to talk about the spine braces, I'll tell you the most commonly spinal braces used are for either scoliosis or to stabilize the dorsolateral spine. Okay, so when you're talking about the stabilization of the dorsolateral spine, one one brace which is known as Taylor's brace. That's what we call Taylor's brace, Taylor. Okay, this is for dorsolateral spine immobilization if you want to stabilize it. Then you have this one, which is what you call Milwaukee. Milwaukee is for the spinal scoliosis, in children's spinal condition called scoliosis in children's. But when you wish to use in adolescent, then you use the Rizer's cast. I don't have the image here. I'll show you from my spine topic. So when you talk about the spine, the scoliosis in a child can be treated by Milwaukee. But when you're talking about adolescent, then you use another spinal brace that's known as the Rizer's cast. That is known as the Rizer's cast. I'll show you how the Rizer's cast look like. So Rizer's cast would be somewhat like what this dummy is wearing, right? That's what you call Rizer's cast. Okay, so Taylor's, Milwaukee, Rizer's, these are important ones for your spinal stabilization. Okay, these are the ones. What else, guys? The spinal braces. So Nalini, I would just suggest you download this file, keep it safe with you, open it up when you go for INI, when you go for the NEET, just open it up, go through it once, and it will help you out in all the exams. Okay, these are the braces. These are other braces, the Taylor's, the Thomas splint, and the mermaid splint. Okay, so this was Taylor's which I showed you. That's what you call a aeroplane splint for the brachial plexus injury. This is a foot drop splint for foot drop, obviously. This is an important one, the knuckle bender splint. For what? The claw hand, so that you can keep the knuckles bent. That is knuckle bender splint, and that is to keep the wrist elevated like this. That is for the wrist drop, so that it is elevated like this. That's what you call the wrist drop. Okay, so this is about these braces. This was the splint for the CT issues. That's your Dennis Brown splint. That is your Dennis Brown splint. So remember that, please. And yeah, the lower file is all about the traction. So I would recommend you to go through this file once. Okay. So that is from this area, the splints. Right. So guys, I think that is all I had for you. I had taken up all the queries that you have shown, send it to me via Telegram, via WhatsApp messages. Okay. And I believe that Sapna, Nalini, Manohar, Crayon, MD, you all are, guys, you all have prepared well, have belief in yourself, have confidence in yourself, and you are surely going to do the, get the best in the exam. Just with a cool and calm mind, sit in the examination hall, think that, believe that you have read everything and you can easily fetch out the answer in all the questions. So have confidence in yourself, with full positivity, cool and calm mind, go for the exam, and you are surely going to rock it. Okay, so all the very best, guys. If I can be of any other academic assistance, feel free to reach out to me. You can search me as Sushil Vijay on the Telegram group, and I'm very much active on that group so that I can answer the maximum things. Okay, so do let me know if I can help you out somewhere else. So my bestest wishes to all of you guys. Just go for it, and you are surely going to rock it. All the very best. Thank you so much.